Good afternoon, ladies and gentlemen, and welcome to the session this afternoon on workforce. We're going to be talking this afternoon about preparing today's staff for tomorrow's challenges. And I'm delighted to be joined by a panel of people who I'll introduce in a few moments. But before I do, I want you to listen to a little quote that was first published in the Lancet in 2010. Health is all about people. Beyond the glittering surface of modern technology, the core space of every healthcare system is occupied by the unique encounter between one set of people who need services and another who've been entrusted to deliver them. So that's what our workforce is all about. That's what we're trying to create, the workforce of the future who we trust to care for us at our time of need. My name's Ian Cumming. I'm the Chief Exec of Health Education England, which is the ALB that's charged with workforce matters in the NHS. I'm joined today on my panel by Professor Jane Dacre, who's consultant physician, rheumatologist by background, but is the president of the Royal College of Physicians. We also have Dr. Amanda Doyle, who's the Chief Clinical Officer from NHS Blackpool CCG and the co-chair of NHS Clinical Commissioners. Dr. Ruth Mays, who is the incoming Chief Nurse of Monitor, and Dr. Jennifer Dixon, who's the Chief Executive of the Health Foundation and by background a consultant paediatrician. So, health is a team activity. Healthcare is not something that we deliver on our own. What I want to do is to set the scene by talking a little bit about the problems and challenges facing us at the moment in our healthcare system with regard to the workforce, to then talk a little bit about some of the areas in which I believe we need to be taking action in the immediate term, in the medium term, and then to focus for the last few minutes on some of the longer-term global issues that are going to drive how we deliver healthcare in this country and therefore drive the sort of workforce that we need for the future. So, this slide shows, if you look at the pale blue line heading up in a roughly 45-degree direction towards the top of the graph, that is the actual percentage increase in employment of consultants in the NHS, 2003 to 2013. So this slide is not about projections. This slide is actual people in post. So 2003 to 2013, you'll see that very significant, almost 50% increase in the number of consultants in our NHS. If you look at the line that finishes at about just over the 10% increase mark at the bottom of that graph, you will see that's nursing and midwifery. That's qualified nurses, qualified midwives. So in the same period from 2003 to 2013 that we saw a 50% increase in the number of consultants, we saw somewhere in the region of a 10.5–11% increase in the number of qualified nurses and midwives. So the first question I'd like to pose for you this afternoon is, do we think that might explain some of the issues and challenges that we've had with the quality of care? Because by and large, our consultant workforce are generating activity that are patients who are requiring to be cared for by nursing and other support staff. The other comment I would make on this slide is to look how straight the consultant line is. Is that because we protect medical education? Is that because we believe that doctors are special and we're therefore not going to vary from that trajectory? No. It's because of the length of time that people are in medical training for means that they are far less susceptible to peaks and troughs as a result of other changes in our healthcare delivery system. What other changes do I mean? Well, you could map onto that graph various economic cycles and peaks and troughs facing the NHS. So 2003, we saw the stated objective to increase the spending in the National Health Service in this country to meet the European Union average, and we saw the increase, the acceleration in recruitment into new posts in this country. We then get to the 2006-2007 period. Many of you will remember this. Money gets very tight in our National Health Service and everything slows down. So look at the graph. The consultant line continues up. All the other workforce lines, by and large, suddenly take a downward trend as we respond to the economy, as we respond to the fiscal tightening within our National Health Service. We then start on the upward trajectory again, as money becomes more available, as we move out of that challenged financial time, until we get to the 2008-2009 global economic downturn, and then look what happens to the lines again. All apart from the medical line, we bring them back down to deal with the financial challenge that we're facing. So, did we mean to do this? Is this what we meant through workforce planning? So we are going to respond in some staff groups with short-term measures because of financial challenges, whereas other staff groups, because of the length of their training, we continue to produce and we don't move away from that area. So one of the areas that I want to talk about in this session is why we have such a shortage of nurses in the NHS and indeed in social care and independent sector and private hospitals as well at the moment. Is it because of a failure in workforce planning, or is it because the service has changed during the time that we're considering? And I would argue it's the latter. Workforce planning has actually worked, and this is nothing to do with HE, this is predecessors. Workforce planning produced the number of people that SHAs and others plan to produce. The difference is the system suddenly decided to respond to the challenges of mid-staffs, of Francis, other concerns about quality, by requiring more qualified nurses. So, if you look at this graph for a moment, you'll see the bottom dotted line, this one here. That is the 2012 responses from NHS employers in this country in terms of what demand do you want for nurses in the future. So in 2012, the aggregate of every employer in this country said they're going to employ fewer nurses in the future. This was because the belief that the transition of care from the acute sector to the community sector was going to be speeded up, we'd be closing more beds down, and therefore we need fewer nurses. So that's what the NHS said in 2012. In 2013, the orange line. So we'd started to move away from that. And think about where we are now in terms of the cycle, in terms of mid-staffs, in terms of the Francis report being published, in terms of the public inquiry. So hospitals in particular, because if you disaggregate this graph, this is driven by hospitals. There's been very little change in the community demand for workforce. So if you look at this 2013 line here, we're actually saying, well, we need a few more than we said in 2012. But look what happens in 2014, this dotted blue line here. This is what our NHS is saying at the time that we last collected data, so that's approximately 6 months ago, 9 months ago. This is what our NHS hospitals are saying they now wanted in terms of nursing numbers. This solid line, this solid blue line, by the way, is actual people in post. So, given it takes roughly 4 years to produce a nurse from the day somebody orders one, what we're now seeing is output from nursing schools to meet this bottom line here, because that's what the workforce planning was for. But let me quantify the mid-staff's effect for you. 21,000 additional registered nurses in the acute sector in our NHS. 21,000. That is the entire output of the whole nursing commissions for England for 1 year. This graph at the bottom shows what's happened with adult nursing commissions. So a deliberate downward trajectory from our predecessors in 2010-11, 2011-12, 2012-13. We're then starting to see an upturn in what hospitals in particular are saying they wanted, so we see an upturn in the number of nursing commissions. This dotted green line is what we've got in the system now. These are people at university. So if we continue with what we've got now, by the time we get to 2019, we'll have roughly the right number of nurses. That doesn't solve your problem at the moment. So we have to solve the problem at the moment through a mixture of return to practice, of which there's about 1,500 people currently going through return to practice schemes, and also through initiatives such as international recruitment and other ways of working. So let me talk a little bit about the future then. We have a challenge in the future in that healthcare is not going to be delivered in the way it's delivered at the moment. And that's not necessarily as a direct result of anything that we do through the 5-year forward view or as a direct result of deliberate changes that are brought about in this country. But there are global drivers of change that mean that our future workforce will look different. The first of those is the money, and Simon's already talked about this today, so I'm not going to repeat that again, but we know that we will be getting £8 billion over the course of this Parliament, but we also know that the likely increased demand is going to be much, much greater than that. Just to give you a couple of quotes from Public Health England, a third of babies born this year will see their 100th birthday. A third of babies born this year will see their 100th birthday. In 1948, 50% of the population died before they got to 65. So that is such a radical change in terms of life expectancy. Part of that is due to the success of our National Health Service, by the way, but that is such a radical change that means we have to think very differently about the future workforce. Genomics. England is leading the world in terms of the genomic revolution, in terms of the 100,000 whole genome sequencing. This is going to have a revolutionary impact on how we deliver healthcare. And this isn't science fiction. This isn't something that's going to happen in 20 years' time. This is something that in the next 5 to 10 years' time will be into a completely different area of prediction and prevention rather than diagnosis and treatment. Are we equipping our workforce to be able to work in that environment? Informatics, and I'm not using the narrow definition of informatics here, I'm using the broadest definition of informatics. I see many people here today are using iPads. I'd like to predict that iPads are going to be the primary care of the future. That is how we are going to want to access our initial healthcare resources. The Facebook generation are not going to want to go and sit in GP surgeries. They're going to want to FaceTime. They're going to want to Skype. They're going to want to Google. There's a little survey being done recently in a university asking young people at university if they thought they had a sexually transmitted infection, what would they do? Number one answer, Google it. What's more interesting is they then said, and then what would you do if you thought you did have a sexually transmitted infection? Answer, try and buy treatment over the internet. That's a significant shift in where we've been in the past. Now, we can either say, this isn't going to happen, we don't like this isn't safe, or we can design a workforce to operate in that environment to respond to what the generation after us is actually going to demand in terms of healthcare. And finally, how do we link all these together? So a constrained financial environment, significant change in how healthcare is delivered coming through genomics, people using technology far more. The picture up on that slide is of a health booth that allows people to access primary healthcare from a booth that could be situated anywhere, and of course the healthcare professionals could be anywhere in the world. And how do we deal with the demographic time bomb and the demographic explosion that we're faced with? So enough from me. What I'm going to do at this stage is to hand over to our panel to ask them to say a few words about what they think the particular challenges are facing the workforce and areas that we may be seeking to address some of those challenges. So first of all, I'm going to introduce once again Jane Dacre, who I've already mentioned is President of the Royal College of Physicians, who's going to give us her thoughts and perspectives. Jane.
Thank you very much, Ian. Well, my perspective about what's happening...
Could we have the microphone on, please, for Professor Dacre?
Should I say testing, testing?
Yep.
Can you hear me now? Yes? Thank you. I'm going to start with a word, and that word is change. And I think there are three things that need to happen for the workforce of the future, and they are change, change, and change. Because we have a vision for the future of the workforce, which has been very ably articulated before us, but our vision for the future is clouded with dealing with the crisis that's going on today and has been going on for a long time, and with a workforce that was created yesterday. And we have to find a way of making that work. And the answer is around the word change. There are some things that are changing around us. Some of those have been described already. There are some things that don't need to change. And there are some things that we need to change. So the changes that are happening around us are things like 2/3 of patients coming into acute hospitals nowadays are over the age of 65 because of the demographic change of the population. Those patients have more than 3 things wrong with them, usually. Hospital admissions are up by 37%. Mortality at weekends is up by 10%. 40% of patients who die in hospitals don't have medical needs. And so those things are what prompted the Royal College of Physicians to write and promote its Future Hospitals programme, which is a blueprint for change in the health service. And the demographics and the change of the workforce need to change to keep up with those changes in demand. Another change is a change in the profession. You'll notice that the panel here looks a little different than a panel might have looked a few years ago. So can you work out what the difference is? No prizes. The demographics of the workforce are changing. For 500 years, my profession, the medical profession, has been dominated by men. In the last few years, in fact, starting properly in 2017, it will be dominated by women. Some people see that as a crisis. Some of us see it as a welcome change. Those are changes that are happening to us. There are some things, though, that we don't want to change. And in the medical profession in this country, we are blessed to take the top 3% of this country's UK A-level grades and to train them to be doctors. So we have a fantastic quality medical service. We don't want to change that. We need to preserve that. We need to continue to attract the UK's brightest, and we need to maintain the quality of our doctors. We also need to maintain the professionalism of our staff and not allow that to dip, and not allow accusations about poor compassion and lack of compassionate care to ever be true in our medical workforce. But there are some things that we do need to change. We need to keep morale up. We need to change the morale of doctors. Now, in the data that we have, 80% of doctors are happy in their work. That's going up, but a significant number of those doctors are unhappy with the system in which they work. So that needs to change. That relationship between the doctors and their system needs to change. Most of the reason for that unhappiness is actually shortages of clinical staff. It looks as if there are gazillions more of us than there ever used to be, but please note those are percentages, not actual numbers. Thank you. There are not that many more of us in numbers, and if we are to deliver a consultant-focused level of care, we do not need to be reducing the number of people that there are available to deliver that high-quality care. We need to focus on making sure that they're able to do that to a very, very high level. The other problem that the medical workforce suffer, and this is from our survey results, is unacceptable workloads. So workloads that mean that the number of patients that are coming into hospital are too many. So that needs to change. Another thing that needs to change is our appetite for change. We need to learn to innovate in our daily roles. So how do we do this? Some of these changes are cultural, and culture is very difficult to change, but there are some no-brainers that we need to work on. Perhaps the first is the delivery of a 7-day service without reducing the quality of care. The second for us as doctors is that we need to value the generalist doctor as well as we value the specialist doctor. There's been an erosion of the value given to the good general physician over the last few years, and we need to change that round. And that's an issue for us of professional identity. We also need to work out how to do this. Now, I am a fan of the general principles of the shape of training. That is the right answer, but it needs to be delivered in a way that brings people with it. And so that means a new definition of the F word, which is unusual for those of us in the health service, and that definition is flexibility. So we need to have flexibility of the provision of medicine for patients. So that includes being a generalist as well as being a specialist and valuing both equally. We need flexibility of the delivery of care, and that means we have to get off our bottoms, out of hospitals, out into the community, and start to deliver the care where the patients are. We also need flexibility for the demographics of the workforce. We need more people like us in charge, and we need to ensure that the health service makes the most of all of its staff. So we need to value the equality and diversity of the people that work in it. We need to make sure that whilst we do that, we do it well. And so even though we support the shape of training, we don't think that it can be delivered in less time than there is currently without sacrificing the quality of what we do. So in order to work across the whole system, you have to work across the whole doctor's life course. So we need to start in medical schools, and we need to contribute to the development of that change all the way through, from cradle to grave, from conception to resurrection, from beginning to end. How do we do that? Well, we have a few blueprints that have been developed. Our own blueprint is the Royal College of Physicians Future Hospitals programme. Simon Stevens' 5-year forward view is another one, and the shape of training, which is another blueprint. So we have plenty of plans. What we have to do is implement those plans. That can't be done from top-down dictatorial telling us how to do it. What it has to be is a social movement. So every doctor, every physician needs to feel empowered to get involved in a social movement. They need to look at the system around them, and they need to have the skills and the confidence to change that system. So we need to empower, to educate, to engage, and to focus on equality and diversity. Thanks
so much indeed, Jane. Thank you. Amanda.
So I'm going to talk about general practice and community services, not because I'm a GP, but because as a commissioner, if we're really going to step up to the challenge around transforming services, around implementing the 5-year forward view, around moving more care out of hospital and developing a sustainable service for the future, then we really, really have to focus on primary care and community services. And I don't know if it's technically possible, but if it is, could we have Ian's first graph back? Because I think that's really quite interesting. We looked at the ever-rising blue line of numbers of consultants, but actually hidden down at the bottom in a bit of a flat zigzag was an orange line. There we are. That's numbers of GPs. We're planning a service in which primary care is the linchpin, in which care moves out of hospital, in which primary and community care delivers ever more of the service to patients, those patients Jane talks about who actually aren't benefiting from stays in hospital. And that orange line is the number of GPs, and the numbers for community nurses are equally flat or flatter. Now, we've all obviously breathed a sigh of relief when we heard the news last week that we're getting 5,000 new GPs. But last year, 261 GPs joined the NHS. Where are we going to get 5,000 from inside 20 years unless we do something radically different? We're not. And that's the number of new ones we need to start delivering a service, as long as we retain the ones we've got. And we're not doing that either. So in Lancashire, where I'm based, 38% of our GPs are due to leave or retire in the next 10 years. How many more do we need to produce to give us 5,000 extra at the end of that period of time if we're losing them at that rate? So there's some real issues, not only about training more GPs, about finding them from somewhere, and it's not that easy to do. The rest of the world doesn't produce GPs in the same way we do. The job isn't the same. But making the jobs we've got, the services we've got, somewhere where people want to work. Our problem isn't necessarily getting enough people wanting to be doctors. Our problem is getting a proportion of those people to want to be GPs, and you can see the difference in increases in numbers of hospital doctors and GPs. Every year, am inundated with really bright, keen 16 and 17-year-olds who want to come and do some work experience with me because they are desperate to get into medical school. And they would love to come and be GPs in Blackpool. And every year, we have an increasing struggle to recruit GPs in Blackpool, because only a very tiny proportion of those really keen, bright, local 16 and 17-year-olds get places, and they go off and do other things. And nothing about the system and the workforce planning system we've got enables us to tailor local needs to train local people who we know are more likely to come back and want to work in places like aren't the centre of the universe, which are very deprived, which have huge needs, but perhaps aren't as attractive as central London and central Manchester and these sort of places. So we need to do something about the mismatch there. Community nurses, we are not training community nurses. You cannot find them for love nor money. It's really, really difficult. So the situation is fairly dire. We need to stop talking about what a big problem it is and start coming up with some solutions. And as well as the solutions that Ian's talked about, which are going to pay off in 10 years, because that's how long it takes, we need some immediate solutions that are going to enable me to commission a sustainable out-of-hospital service in Blackpool in 5 years' time. So what are the solutions? Well, I think it's heresy to say it. I think we need to start overtraining, significantly overtraining. Let's accept that the workforce is feminised. Let's accept that a large proportion of those people want to work part-time. Let's train significantly more than we think we're going to need. And okay, it makes it a competitive environment at the end of the day, but why is that a problem? We don't perceive it as a problem in any other area. Why is it a problem in medicine? If we've got 10 people applying for jobs, that's great. At the moment, we will take anyone who can produce a certificate to say they're qualified to do the job. And that's ridiculous. So let's start overtraining. Let's look at solutions for very quickly getting people into training. So, every university in this country nearly has a course full of people studying biomedical sciences because really they wanted to get in to do medicine and they didn't manage it. So where are those courses overlapping? How quickly could we convert some of those students into medical students? How quickly can we get people through? And I'm not proposing we shorten training, but we need to look at what we've got and what our starting point is and how quickly we can move. Let's look at pharmacists. We overtrain pharmacists. We've got large numbers. They are experts in use of medicines, but they're also clinicians. We can develop their clinical skills. They can not only be fantastic around medicines-related issues, but they are great as managers of long-term conditions as part of a clinical primary care team. Let's get them doing it. Let's develop their skills. So let's think of some solutions rather than all sitting around shuffling the deck chairs and talking about what a big problem this is. And the other thing not to forget is we need some great managers in the NHS. The size of the challenge is enormous. We need really highly skilled, keen managers wanting to work in the NHS to help address some of this challenge. And I'm not sure how many bright young graduates leaving our top universities this month are looking to be NHS managers. I suspect not large numbers, and we need to do something about that.
Thanks, Amanda. Much appreciated. Ruth.
So for nurses and midwives, I suppose I'm using the 5-year forward view as a basis. And if we use that, for me it's...
Could we have Ruth's microphone on, please? Thanks.
Can you hear me now? Yeah. Try again. Testing.
No. Could we have Ruth Mays' microphone on, please?
Hello?
No?
No, it's not working?
Not working. Would you like mine?
Don't mind. Oh.
Oh.
Does that work?
No, there you go, you got one.
No?
Switch it on.
Thank you.
Not much luck.
Here. And is it working now?
Yeah.
Ah, great. Okay, I'll start again. Thank you. So for nurses and midwives, the 5-year forward view provides us a basis of how, in reality, some specialist services are going to move out into the community. And for me, there is a nursing and midwifery challenge around that, not just in terms of numbers, but also in skills of the workforce. But just taking skills of the workforce first, HEE have done a lot of work about their value-based recruitment, and in many ways, up and down the country, lots of our providers are doing the same using the CNO's strategy. We've seen some great results of more people coming back into the service and also retention of staff by using that values-based recruitment. We've also seen some really great examples of apprenticeships being started. In Norfolk and Suffolk, there's a great one where the health and social care experience is coming together, and that is exactly what we need more of going forward for the implementation of the 5-year forward view. With regard to numbers, in the post-Francis era, in the development of the NQB guidance, and indeed every organisation, every provider, reviewing the need of their patients, reviewing what staff they've got, and indeed looking about their future activity projections, we have needed and we will continue to need more nurses. With the increase in personal health budgets and more frail and dependent patients being treated in care homes by the social care sector and independent sector, it shows that this is not just something for the NHS, but also for social care and the independent. Monitored TDA and the NHS England are working together, and you've seen some of that in the last couple of days by the fruition of those letters about how we want to support providers, cap the agency costs and reduce the spend. But what we have seen is HEE decide to increase the commissions for training registered nurses by over 13%. But even with this increase, these registered nurses won't come to fruition until 2017. So other options need to be explored by us in this room and by our profession. There is a gap, there's a huge gap between the care certificate and the graduate. It is too big a gap in my view. We need to consider multiple routes into nursing. We need to consider how we work more as parts of teams, although there are some fantastic examples of how nurses and other professionals, physiotherapists, OTs are coming together to provide that registered workforce for particular wards and services. But in my opinion, we need to further consider the vocational training and therefore the role of the Band 4. That blend of the workforce, working closely with our profession and indeed our professional regulator, the NMC, is what I see as an option of going forward. So for nursing and midwifery, the future workforce models are going to be complex, but actually, let's use this 5-year forward view. Let's use it as a big opportunity for some radical change. Thank you.
Thank you, Ruth. Jennifer.
So I better just test to see if this. Oh, good. That's good. It's on. Thanks very much. So I don't know about you, but I sometimes read the Harvard Business Review, and there was a very interesting article about 6 months ago, and it talked about healthcare and how healthcare was changing. And it said, in the past, the way that we change care is that we unfreezed current models. We then redesign them and then we refreeze them. And it said, that's old thinking. The future is permanent slush. That's what we need to cope with. And I think that echoes what Jane has to say. So how do we help our staff, particularly our clinical staff, because as Simon mentioned today, it's about frontline change, a lot of these efficiencies and quality changes we need to see in the future. How do we help them cope with permanent slush? So I've got 3 messages from my position at the Health Foundation. Just a note on the foundation, just in case some of you are wondering what it is. We give out about 12 million a year, mostly to the NHS, on projects to improve health and healthcare. And so over the last 10 years, we've given about 120 million. A lot of that has been on frontline clinical teams trying to make change. And one week, a few weeks ago, I was in the lunch queue with a consultant who'd led one of our projects. And he talked to me and he said, how on earth can I get trained in making change? He said, I've been resorting to Googling and looking at Amazon, books on Amazon on how to make change. What can I do? And it struck me that there are quite a few clinicians in this position. And what he was after was something on what he called quality improvement. And by that, he meant how to re-engineer his clinical pathway to try to make changes that are needed, that detailed work that is needed to make any kind of change with the team. So I then, of course, started looking at some of the courses that we've got hanging around, and the undergraduate and postgraduate for clinicians. And sure enough, there are a few places where clinicians can be exposed. Some of the AHSNs are making big progress in this area, such as Manchester and Imperial. But actually, if you think about it, there isn't a great deal of necessary encouragement for these kind of skills. Well, they're almost engineering-type skills that IHI have tried to develop over here. And I think we could do, if we want better dosage of these skills around the place, we need to do a bit more than we are doing at the moment. And that means probably at a postgraduate level and probably on the job. We might consider MOOCs, mass online courses. We might consider a range of things. Anyway, whatever we do, we've got to up the dosage if we want to make the level of change as fast as we do. So that's point number one, I think. Point number two, in our experience at the Health Foundation, clinical teams make fantastic changes. They are enthusiastic, they have energy, they make brilliant changes at the front line. But what happens is that after a while they get stuck. And that's because the changes they want to make are but against other parts of the hospital. It's the medical record system, it's the information system, it's how outpatients is managed. And there, the clinical teams find, particularly the clinical leads, find that they don't have the skills to negotiate those bigger changes. They kind of get stuck, they get burned out, they throw themselves against these brick walls and they fall back hurt, and eventually they give up. So these projects that do well for 2 years fizzle out and don't go anywhere. So what they need, as they're describing to us, are, I don't know what you'd call them, management, negotiation, leadership kind of skills, to negotiate with other parts of the forest in the hospital, say, or other providers, to make the kind of changes that they need. And this is hard work, but they're not going to get very far if it's just frontline quality improvement. There has to be wider changes. And the more we want to have new models of care, the more complex those skills will need to be. So that's, I think, point two. And just a footnote on that, I'm a very sad person, actually. I read a book. I went to a presentation at the King's Fund a few weeks ago by one of the leading clinicians at the Mayo Clinic. And he flashed up the front cover of a book that's been written about 50 years at Mayo, how they became the most top-class, high-quality organization, healthcare organization in the US, having started in a cornfield in Minnesota. And what was absolutely crucial about this was the way they deal with their clinicians, the way they train, and also the way that they encourage and groom, particularly medical staff, up the hierarchy. And there's nothing about leadership in this. There's nothing about going off and doing an MBA. It's about learning on the job. And they don't have the word leader at Mayo. They have you get to a certain level of clinical experience, and then if you're good enough, you're tapped on the shoulder and you're asked to serve. And you serve because your values is very strong. It's the Mayo values and so on. And in fact, there was an amusing anecdote that they don't tend to promote anyone in medicine into leadership roles if they've got a large signature. There's a big correlation between size of signature and poor performance. So, which they reckon was something to do with ego. So they like egoless technocrats who are managers, who are quiet people who get on with it and do it. So anyway, that's quite interesting to observe. I recommend the book. It's by Dan Berry, if anyone's interested, for those of you there. And the other final thing to say about Mayo is they don't have doctors managing necessarily. They are twinned at the hip with managers, and they work as a unit. Okay, so that's point two. Point three is that you cannot have clinical staff doing basic management in providers. That's not what they're trained for. What you do need is you need absolute top-class operational excellence. I think we'd all agree with that. Technical operational excellence. And Ian, on your graph, you didn't show the management line, but the management line on that graph for the last 10 years is the percentage annual change is precisely minus 0.2%. over that period, at a time when we really need the best possible management, as I suspect Lord Carter and Stuart Rose, when those reports come out, will probably underline. So this is way beyond my comfort zone to talk at the Confederation about management, having come from a clinical and foundation background. But there has to be something in there about looking again at our management layer, particularly operational management. How these people are supported, how many, what's in their skill set, what should be in their skill set, vis-a-vis a whole range of things, how they can better create order out of what is often disorder in some of our biggest institutions. So that's another big area I think we need to look at. Thank you.
Thank you very much indeed. Okay, over to you. We've got about 10, 12 minutes to take questions, to help stimulate the discussion and the debate. As you've probably heard, I can't see terribly well because of the lights, but if you could wave your hand, and we've got people with microphones coming to you, and we have somebody up there with microphone number 3 headed in your direction. Thank you.
I'm Ian Smith from Four Seasons Healthcare. 2 comments and a question. Firstly, I was glad that most of you did mention community nursing and nursing in care homes. I think too often we think about nursing shortages just in hospitals. The nursing shortage out of hospital is really chronic. We have at the moment probably 500 nurse vacancies throughout our organisation. Secondly, I'm sure you'll join me in decrying the government, who are in complete denial about this problem. The question, though, we've decided as much as we can we're bringing in foreign nurses. We have launched a programme now, so I think the days of the SEN, the state enrolled nurse, has gone, but nonetheless I think there is a role for an intermediate qualification, probably as an entry grade into the nursing home sector, that can develop over time to the sort of position which was the old SEN role. And my question is, what can you do to support us?
Okay. Ruth.
Somehow I guess that might come to me. Thank you. I think I said in my few words is that we have had a huge increase in nursing, but actually, and in registered nurses, but actually that's been mostly focused into acute. I'm very aware that there's a big gap between the care certificate and indeed the graduate nurse. And I do believe there is something around us supporting and considering much more how we recruit and train our Band 4s that work across all of our sectors, in social care and in independent sector and in acute and in community, but with the right skills and competencies. So I think there is a role that we need to further explore and work very quickly on our Band 4s.
And just to perhaps give the HEE perspective on that, we firmly believe that there is a need for a role that sits between the healthcare support worker and the degree level registered nurse. And what we want to do now is to take forward a discussion about what are the competencies that individual, what's the training that individual requires, what's the remuneration, where do they sit on the banding scale, what are they called, that whole debate. But we're very clear that we believe we need to be creating that role. Number 4.
Matthew Wynne from Cambridgeshire. A comment. Ian, you mentioned that you didn't think that the provider and the workforce planning elements were that far from each other. I kind of disagree with you, because what would characterise, certainly in our sector, workforce planning is what Monitor and the TDA said you could afford, and therefore your workforce plan went in with those numbers. So it's not kind of a light bulb moment that our numbers are different to each other. So I suppose that's one issue, that I think we have a disparity in commissioned versus what we all really need. And the second issue, which I guess goes to Ruth and other people with HEE, and it's great that Ruth is a clinical leader in Monitor at last, great for them. But the second thing would be, how do we start planning our workforce on pathways and areas that actually patients use rather than organisations? It is really stupid that we don't look across a frailty pathway, about diabetic, about paediatrics, and plan our workforce together. But our planning is done on organisations, and that causes schisms and problems between us all.
Okay, let me quickly pick up the workforce planning. The point I was trying to make was that the numbers of training places that were commissioned, not by us, by our predecessors, actually matched the workforce plans that people were submitting at the time. So if the workforce plans were wrong, then the numbers were wrong. But actually, I'm not convinced they were. There is a significant difference, and there remains a significant difference between the workforce plans that employers submit to Monitor and TDA and the ones they submit to HEE. And one of the things we've got to stop doing is to write different plans for different audiences, and we actually need one version of the truth. What is the workforce that you believe you need for the future, so that we can make sure that we can commission for it. If that workforce isn't affordable, I actually think that's a separate debate, but we need the plan around what do you actually intend or want to recruit in the future. On the issue of how do we plan for pathways, Amanda?
I mean, we clearly need to do it. How we do it, I'm not sure, but I think what's really important is looking at the way our workforce and the work we want them to do is changing and trying to plan for that. So nobody asked me in primary care when they were doing the workforce planning about what I might need, but I probably employ 5 or 6 times as many nurses as I did 5 years ago or 10 years ago. And now they prescribe, and 10 years ago not one of them prescribed. And now the majority of them are specialist nurse practitioners, and 10 years ago none of them were. And it's not just about numbers and counting what institutions need, it's looking at the changing role and how are we developing staff and how are we systematically training our nursing and other workforce up to these enhanced roles to take a greater part in what we do out of hospital. So it's the pathways stuff is the key to it. Look at the pathways and look at how they're going to work. I'm not quite sure how Ian goes about it.
Jane?
I'm a sceptic about workforce planning. I'm aware that when the X-ray was invented and presented at the Royal Society, people said this is a hoax, it's never going to catch on. And I think that workforce planning, certainly in my lifetime, has never been lauded for getting it right. Therefore, we have to recognise that it's a flawed science, that we're not going to get it right, and we have to make provision for that. And the way to do that is to use the F for flexibility word. So if you have and train up a workforce that has the potential to do a number of different roles in a number of different environments, and if you encourage a culture that says you need to be flexible, then you can tailor your workforce to the area of work that it needs to be to fit to. So you can have geographical variation, you can have changes in the demographics of the population, you can have changes in the skill mix. So what we ought to be doing is training the workforce up to a level at which they achieve their competencies, but then doing just-in-time training for the job that the service needs them to do. You might call it credentialing.
You might. Okay, I think we've got time for one more question, I'm afraid. I'm sorry, I know there's a lot of hands up. Should we go to number 1?
Hi, Cathy Winfield, I'm Chief Nurse from Derby Teaching Hospitals. I think what really comes across to me is we're still really thinking in professional silos, and I think if we're really going to take the 5-year forward view forward and really transform care, and I think Ruth touched on it with the Band 4 roles, we've got to really think differently about how we bring health and social care roles together, work generically, and really build those competencies. And I wondered what your thoughts are in relation to education commissioning and how we're going to drive forward that change.
Integration of health and social care. Amanda, do you want to start?
So I think that's absolutely right, and it's not just about the clinical workforce. So one of the things, we have an MCP Vanguard locally, one of the things we're looking at is generic training of the untrained workforce around wellbeing support workers, around some of the generic skills that workers across health and social care are going to need to support our integrated out-of-hospital teams. And I think it's really important that we think in those terms and actually commission some development locally. Not everything has to be done by HEE and not everything has to be planned 10 years in advance. We need to get a bit smarter about how we're going to work locally and how we're going to get the staff that can do that for us.
Jennifer, any thoughts?
No, only that on the train on the way up I was reading about the £1.2 billion contract let in South London for frail older people's care, which runs across the NHS and also the local council for health and social care. And it strikes me that when we get scale of that level, then I think we will become much more au fait with what new skills are needed. It's almost as if we need, as you say, some development work to understand what is needed and how existing roles flex into new arrangements and which ones don't, before we then can start commissioning in earnest. So we've, in a sense, got to sit alongside the vanguards and current new models before we can even think of any commissioning in a new way.
Thank you. Well, thank you for that. I think that's been a really interesting discussion, both in terms of the questions, but also the views and perspectives from the panel. I think there's a few things we have to pick up from today. First of all, doctors and healthcare professionals who are in training at the moment will still be working in healthcare in 2055. One thing that is certain is that healthcare will not look like it looks now in 2055. So we have to somehow, picking up Jane's point around having a flexible workforce, a workforce that's willing to innovate, a workforce that's willing to change. And I think we have to start that from the day that people enter training. So we're not training in the model, as one of our panels said, we're not training people to work in the health service of yesterday, we're training to work in the health service of the future. From our perspective, and I know this is a challenge, but if we're trying to create a health service that's delivered in the community within reach into hospital, why are we training in hospitals with an outreach into the community? We need to think about our training models actually matching the service models that we're trying to create for the future. Should we accept overtraining? Overtraining from the employment perspective, certainly I can fully understand, but if you take, for example, to take somebody from day one of medical school to day one of becoming a consultant, that is a cost to the NHS of £700,000. So there is a cost associated with training people as well. I did like that quote about coping with permanent slush, and I think that's something that we all need to take on board, and we certainly need to be building into our training programs. Issues around navigation, leadership skills, coping with strategic change. But I think my favourite comment from this afternoon's session is the one about your size of your signature and the size of your ego. And I wonder how many of us are going to leave this room with smaller signatures than perhaps we came in with. Ladies and gentlemen, can you join me in thanking the panel? We're just going to take a couple of moments now to hand over to the next session. But in that couple of moments, could I ask you to please take time to use the URL and to actually respond to the question about evaluating this session and to give us a view on what you thought of this session and how it could be improved for next time. Thank you very much.